How many people have done any aquatic therapy? Yeah. Where at? At the clinic or what'd they do?
A lot of kitchen counter stuff. They're on the noodle, ankle weights, walking back and forth.
They have a pool? That's pretty sweet. I worked at a clinic in Buford that we just rented out space from the Y in their pool a couple times a week to do it. And then Mary Black, when I worked at Mary Black, they had a pool out there. And there was a treadmill in the pool, so that was pretty cool. Cool. Anybody else? Brett?
It used to be called SSI in Greer, and now it's called like Elite Integrated.
You have a pool over there? Nice. Anybody else? Alright, we got chapter objectives. Read those and then we get into the chemical reductions. So when we talk about hydrotherapy, aquatic therapy is more when you're talking about the pool. Hydrotherapy transfers heat through conduction or convection. What's the difference? What's conduction? Direct contact. What's convection? So convection is more like the whirlpool, jacuzzi, hot tub, whirlpool, something like that. We do it in various different tanks, starting with extremity whirlpools, and most of the time those are going to be used for wounds, but you can also use it to strengthen wrists and things like that, all the way up to Olympic-sized pools. The main therapeutic effects that we're looking for are to help with wound care, unload weight, and reduce edema. And then the specific tank or instrument that you use depends on the treatment objectives and the pathology. So we can use warm or cold water to help treat musculoskeletal dysfunctions. And we usually submerge either part of the body that's affected or the whole body. And then the temperatures range, we'll go over those in a little bit. So, some of the therapeutic effects: decreased tone, pain relief, increased blood flow, vasodilation, wound debridement, if we need to increase core temperature. Indications: these are the reasons we would do aquatic and hydrotherapy. Arthritis, they use it for burns, edema, range of motion, residual limb wound care, joint stiffness, muscle spasm, strength, pain, all that stuff. And then our contraindications are listed here. Most of these kind of would make sense, like incontinence and open wounds and decreased sensation, any active bleeding, all of those make sense. Cardio and pulmonary diseases, we can treat cardiac patients in the pool. We just have to be careful of the temperatures and the depth that they're going. I think later on in the slide it talks about using it for cardiovascular stuff. But advanced cardiovascular stuff is the key for those contraindications. And then maceration. Does anybody know what that is? So it's kind of like when you've been exposed to moisture for too long and your skin kind of deteriorates and breaks down. So like not the wrinkly stuff that you get when you're in the pool for too long, but if you continue to stay in the pool every day for too long, to those wrinkles, that skin gets soft and easily damaged and destroys some of the skin cells. So if anybody that has that, if anybody's been in the hospital and they've been in a bad hospital where they sit in their waist for too long, they could have some of that around the genital areas. So you won't want to get them in the pool. Let's get into some physics. Buoyancy. Everybody know what buoyancy means? Essentially, basically, yeah. But if we want to get technical, there's an upward force on the body when immersed in water equal to the amount of water that has been displaced by the body. Essentially, all that means is you float, right? So if you take a cup of water, it's not full all the way to the top, and you drop some ice in there, that ice displaces the water level rises to take the place of the ice, and that's essentially what that fancy definition is saying. So the ability to float in the water results from a specific gravity of less than water. We'll get into that in a second. It helps to support the patient's weight, and the joint stress is lessened, and the patient might be able to perform water-based exercises with less pain. So essentially there's a relative weightlessness to the body. We'll talk more about that in a second, but when you get in there, if you're up to the waist in water, then that's taking like 50% of the weight off, 50% of gravity. If you get up to like the chest, the axilla area, we're at like 75, so you're only 25% weight bearing, and then up to the neck, we're at like 10%. So that's kind of how you can guide that. If you've been non-weight bearing for a while, and they just started getting weight bearing, and get them in the pool, we start all the way up to the neck, so they're only weight bearing 10% through those joints. Start doing some training there, and then progressing down to 75 and then 50, and then get out on pool and start working in gravity. When we get up to the axilla, we can have buoyancy assisted and buoyancy supported. So kind of the deeper you are, the more supported you are. So all the way up to the neck is more buoyancy supported, like less risk of falling over, because the water and that buoyancy is going to kind of help hold you upright. And then as we lessen that, like to the chest would be buoyancy assisted and buoyancy supported, because you still have to work a little bit, so it's assisting, but it's also still supporting it. So the deeper you get, the less loss of balance that you have to worry about. We're only down to the waist or the knees, then they still have to balance a little bit more. So the amount of weightlessness depends on the amount of body that's in the water, is what I'm trying to say. So anytime we get into deep water, and deep water would be where your feet aren't really touching. So you could use an assisted device, a pool noodle, something to kind of help you float where your feet aren't touching. That would be deep water, and those would be open chain, non-weight bearing exercises. Then we progress to that 10% up to the neck. And then they call mid-level is from T12 to the chin. So mid-level depth. And then shallow would be from the knees to T12. So those are all different ways to progress weight bearing. Starting deep water if you need to, and then get your weight bearing restrictions taken off, you can go at mid-level and then to the shallow. Does that make sense? And then resistance is the water molecules tend to attract to each other and provide resistance to the movement in the body of water. Resistance by water increases the proportion to the speed of motion. So the faster you move your arms, the harder it is to move, right? Because the resistance, the faster you're moving, the more resistance that you're getting. It's essentially what that's saying.
And you said mid-level was 212 to what?
T12 to the chin. Then we have hydrostatic pressure. Water exerts a pressure that is perpendicular to the body and increases in proportion to the depth of immersion. Who can put that into plain English? Anybody? Water just puts pressure on your body, right? Give you a little squeeze. The deeper you get in the water, the more that pressure is. Okay? So that's why we can only scuba dive so deep in the ocean, because the pressure gets so great, we need some kind of vessel that can take that pressure before we go any deeper. The pressure just gets more and more. Basically all that's saying. So as the density of the water and the depth of immersion increases, so does the hydrostatic pressure. So when we talked about resistance, moving our arms slow, it's easier to move. When we're moving fast, it gets harder because of resistance. If we were trying to move fast down, it's going to be even harder because the hydrostatic pressure gets more the lower we get. Does that make sense? So hydrostatic pressure is one of the things that can help us with information, or edema that we talked about as being one of the indicators for the reasons we would get in the pool, because that hydrostatic pressure acts like a wrap on a swollen knee or something, right? So that's one of the ways that hydrostatic pressure can help. It also lowers venous return. You have a heart rate reduction, so that's why you want to be careful with cardiac and pulmonary patients in the pool, because they get more pressure, heart rate doesn't pump as efficiently, and then we get the centralization of the peripheral blood flow. So, specific gravity. Anybody remember what specific gravity is? It's like measuring So water has a specific gravity of 1. So the human body will tend to float just beneath the surface because the average is 9.74 or 0.974 for humans. Most people range between 0.87 and 0.97 is the average specific gravity for humans. So if the specific gravity of water is 1, in order to float perfectly on top of water, your specific gravity would have to be also 1. If you're less than 1, which typically we are, then our tendency is to float just below the surface of the water. If we had a specific gravity higher than 1, like a 1.1, we would sink to just below the surface of the water because we have a higher specific gravity. Does that make any kind of sense? So we'd have to be exactly 1 in order to float perfectly with nothing happening. If we're less than 1, we're going to float just below the surface. If we're more than 1, then we sink to just below the surface. Does that make sense? All right. It's confusing me. Our center of buoyancy is very similar to our center of gravity. We work inside of that cone of stability. So in order to establish an upright, stable posture, center of balance, buoyancy needs to be maintained within the base of support. So the center of buoyancy is in the chest region. So if someone has postural issues in the pool and they're leaning forward and we're trying to get them into an upright posture, we can use that buoyancy that we talked about to strap the flotation device on their chest anteriorly, and that buoyancy is going to displace more water and help them to stand up in an upright posture. And then we can do our activities, exercises with a better posture with the help of buoyancy. Specific heat refers to the ability for fluid to store heat, and water can store 4 times the heat compared to air. So you want to consider what temperatures you're working in with your patients and what would serve them best. Cooler water is better for long exercise sessions, warmer water for shorter exercise sessions. So then we have viscosity to think about, and fancy definition is the magnitude of cohesive forces between the molecules specific to the fluid. The greater the force required to create movement in the fluid, and when water temperatures are higher, the viscosity and resistance of the water is lower. So this makes moving in high temperature water easier than moving through low temperature water. So the way you think about viscosity, thickness, is to think about water how we use it every day. So if I put a pot of water on the stove and I crank it up to heat it, I'm getting very physics here, but the heat causes those molecules to start bouncing around, getting away from each other, create this separation, which is what eventually causes the bubbles from being in water, right? As the molecules are spread further apart, when there's more space between the molecules, it's going to be easier to move through those molecules. We take that same pot of water, dump it in the tray, and put it in the freezer. As everything cools down, those molecules start to compact until eventually it turns into ice, and those molecules are a solid, right? So it's a lot harder to move through that. So that's the same thing when we're in the pool. We get warmer temperature water, it's easier to move through there, it's easier to move the arms and walk around than in a cooler temperature. Does that make sense? Total drag force is the force comprised of your profile drag, the wave drag, and the surface drag. You don't have to remember all of these fancy drag terms. Just know that drag force, when you're walking in a pool, you feel that resistance, right? It's not as easy to walk, and that's just the drag that you're creating as you're walking through the pool. There's the wave drag, there's your surface drag, which is your profile drag, and all that. So the force is typically opposing the direction of the body's movement. So if you want to increase some drag force, if you walk in a pool for 10 or 15 feet and you create that drag behind you, and then you turn around and try to walk back into it, it's gonna be easier or harder? Harder is the correct answer. Because you're gonna have to work harder, because now the waves, the drag is pulling that way, and you're turning around and trying to walk into it.
Is it like creating like a whirlpool in the pool when you're a kid and you
You're
turn
trying to
around and go the
walk
opposite direction?
Exactly.
Okay. Because in my head I was like, why does it follow you like that? But then I was like, oh yeah.
Exactly.
Around.
So it's gonna oppose the direction of your movement. Even when you're starting your whirlpool, you have that force that's opposing you. And then now when you turn around, you've got that force that was already there, plus that new drag. Primary determinants of water. I didn't do that slide. Are speed, viscosity, and turbulence. So the speed that it's moving, how thick the water is, and then any turbulence that's created. So we have laminar and turbulent flow. Laminar is kind of what we were just talking about. Flow of water passing over the body in motion that creates a drag. That's that whirlpool we were just talking about. We create that laminar flow. We're resisted against the laminar flow. And then when we turn around, that laminar flow is increased. Flow is greater. So that inhibits movement by resisting forward motion. And then a turbulent flow occurs when fluids flow in erratic or small whirlpool-like circles called eddy currents. So moving against turbulent water will encourage greater resistance. And the way you think about that is if you have somebody in the pool working on balance or just walking around, they have that laminar flow already, and then you can walk beside them under the water doing something like this, where you're creating that turbulent flow that's gonna, it's not a constant, right? We're walking around doing this, and that's trying to provide more resistance. So laminar's in line, turbulence kind of erratic. Easy peasy. Yep.
Isn't there another version where you can do, what is it called when you do auscultations? Like, so if someone's standing on a BOSU ball and you're trying to have a squat and then you just kind of hit their
Like
legs.
perturbations.
Perturbations? So it's like similar.
Same thing, same concept, right?
Okay.
There, we're actually just pushing someone around.
Yeah.
We're here, we're pushing the water, and the water is pushing it. There's a lot of other cool stuff now. People use like water bags, and I've been trying to get some in our clinic forever, so that you can do lunges and stuff with a water bag overhead. And as you lunge, the water shifts, and you have to balance against that. All right, so then we'll get into some of the different tanks and equipments that we use for the hydrotherapy. I'm not going to ask all these specifics, but it is important to know. I don't know if they'll ask that. But I want you to know what they're used for and when to put patients in which one. So for an extremity tank, which is like that top picture, we're just using distal or lower extremities. And they're typically 10 to 45 gallons because they're typically about that big. So if we just want to work on strengthening an arm, or we need to do some debridement and go into a whirlpool, that's extremity tank size. So extremity tanks are more for distal and lower extremities. The low boy tank is when we're just needing larger parts of that extremity, probably typically more full leg. So if we had a smaller extremity tank and we were working just the ankle, great. If we need to get that full leg in there, we're gonna have to upgrade to a low boy tank. They're typically 90 to 105 gallons. Make sense? Extremity small, low boy, bigger pieces. Then we have the high boy tank. And these are the ones that you typically see people doing their ice baths in, things like that. That's for full body immersion, usually chest high. I know it says full body, but chest high is the important one, with the hips and knees flexed. And those are typically 60 to 105 gallons. And we have the Hubbard tank, which is truly full body immersion. We want to go max temp of 102. We can adjust the temp on a lot of these other ones a little higher than that. And we have a temperature chart coming up in a minute. But for the Hubbard tank, we're only going to go up to 102 because more of the body is in there and it's harder to regulate the temperature when all of your body is in 102 water versus just an extremity or the red, whatever. So That one is kind of important. And then after that, we have therapeutic pool, which is where we do our aquatic therapy. This is where we're mostly trying to exercise in a water medium. Temperatures in the pool can range anywhere from 79 to 97, depending on the patient age, bless you, health, and the goals for the patient. So the good things about the pool is we can decrease the weight bearing. We have improved handling because they're a little bit more buoyancy supported, so we have less balance troubles to worry about. They're not going to fall over as easily. We have more control of the amount of resistance, and we diminish those fall risks. And then there's a temperature chart. I'm not going to ask specific temperatures, but it is important to know, especially that 102. We get into whirlpools and the things that will influence the patient's response to a whirlpool is the difference between their skin temp and the water temp. So the bigger that difference is, the greater the speed and degree of temperature change you're going to get. So the response is directly proportional to the size of the treatment area. The larger the area, the more systemically effective. You just put your hand in there, you're not going to get a great deal of temperature change. Put your whole arm in there, you're going to get more temperature change. And then also the age and health of the people. They take longer for older people and younger people and people that are sick or in bad health to get any good positive temperature change or positive response. We'll breeze through wound care, and I don't think we'll touch wound care because Dr. Christie does like a whole wound care thing in special topics, so that'll be a lot more covered. But these are the things you want to look for when you're documenting about wound care. You want to talk about the color, shape, and size, the odor, pulses, sensation, depth. That refers more to the debridement that we do. After completing it, you gotta drain the whirlpool, fill up a bucket with cleaning solution, all of that stuff, and then clean the whirlpool. Then you're gonna rinse it, drain it, rinse it back out, and then clean up the agitator with that same chemical bucket. Run the turbine for 5 minutes, and then clean. Just continuous time on that.
I think you stated that there was evidence now, a lot of evidence on whirlpool is not used anymore for wound care because they hold more issues and more damage.
That's what I keep saying. We need to update that test because if they're still asking it on the national exam, we still have to talk about it. But there's a lot of stuff that needs changed. That's just a personal. So, it's a tank that holds water with a turbine. The turbine creates the whirlpool effect, and that helps to debride the wound. Then the advantages of pool therapy we kind of already talked about. Decreased weight bearing, improved handling, reduced fall risk. You can control these resistance a little bit better. Same thing with every other modality we do. We're going to explain what the patient should feel. Select our water temperatures based on the patient's goals. Refer back to the chart if we need to. Get them in a comfortable position. Turn on the turbine. Time ranges between 10 and 30 minutes. And you can do exercises while they're in there. You work on strength, motor control, things like that. And then thoroughly clean it up when you're done. So when we're getting in and out of the pool, you want to make sure to assist the patient along with the handrail. You have to be with the patient, monitor their vitals, tolerance to activities. These are recommended populations for people getting into pool therapy, aquatic exercise, arthritis, musculoskeletal injuries, neurological deficits, spinal cord injuries, CVAs, cerebrovascular accidents, sclerosis, and even cardiopulmonary diseases, but not as long as they're advanced. Okay. The other thing I would note from personal experience doing some aquatic therapy is people tolerate the exercises better. Maybe they're able to do more sets and reps because they're less weight, but their muscles are still working. So oftentimes what can happen to someone who's got some muscle atrophy after surgery or something, they get in there, they feel great, they're doing the exercises, and as they go to climb that stair to get out of the pool, and gravity starts to hit them, they are gassed. So you gotta be careful not to overdo it in the pool also. Because I've had people before that as that gravity starts hitting them on the way out of those steps, they get stuck. Right? So just keep in mind what they're able to do with gravity and don't overdo it when you're in the pool. So if we wanted to increase some resistance in the pool, we could increase the temperature and length of time in the water and cause them to exert more energy. So the water temperature closer to the body temperature of the patient would not be able to cool the body. Same thing if it's not trying to heat the body. So keeping that in mind if that's a goal. If we're trying to cool things down, a little vasodilation, or if we're trying to warm things up for that, warm up for vasodilation without vasoconstriction. We gotta keep in mind the temperature of the water and their body temperature, and then increasing the surface area will also increase the resistance to movement. Sometimes people, some of the aquatic places will have little dumbbells that are made out of like pool noodle stuff, and you can change and you can add on like weights, different size, and then you can do some curls and some. So we're increasing the surface area that we're trying to move through the water. They also have paddles that look like a dumbbell, and there's little fan blades on each end, and they have like openings that you can twist. So like if all 5 are closed, we have more resistance for stuff that we're doing. We can turn 1 or 2 of those slots on the fan blade open, and then it allows more water to go through. So instead of using weights, we're just changing surface area to fight the resistance while we're doing exercises. Those are pretty good. And then changing the temperature. So if we cool the water down, it makes it feel thicker because those molecules are getting a little more compacted and difficult to move through, which will make activities more difficult. So there's tons of ways that we can change the resistance when we're doing aquatic therapy.
That first bullet point is when it says by increasing the temperature, is that the air temperature outside of the water?
No.
So that,
So increasing the temperature in the pool
okay.
and then increasing their time in the water. So
So
as
those
we-
have to be in combination, that's like one thing that would,
It's like, yeah, two different
Okay.
things. Like, you don't have to increase the temperature and increase the time. You do one or the other, right? So if we've been working at like 98 degrees in the pool or body temperature, it's easy for them to maintain, but then we bump it up to 102 and we're doing those exercises. Now their metabolism is kicking more. They're trying to regulate their body temperature, and so they're working on top of doing the exercises, which is why for the higher heat with fuller body submersion, we don't want to be in there for too long, because then again people can get just really gassed. Body trying to maintain homeostasis.
so both hotter water and colder water extremes are gonna make it spend more energy.
Yes. Yep. And that's kind of where that second bullet point comes in. As the temperature's closer to their body temperature, it's easier to like just maintain. When we change those extremes, it's harder to maintain. If you're going to be in there for longer, it's better to go for cooler water because it's not going to beat them up as much. I need a break. Patient or mechanic machine. The different types of traction are manual, mechanical, and then these last 3 are all gravity based. So positional just depends, we'll go over that in a minute, but lying down a certain way over a towel or a pillow or something, but you're still relying on gravity to create that force. Gravity assisted is like you can fill up a bag full of water while you're sitting in a chair and have gravity pull the water down. Inversion therapy, bless you, is another form of gravity where you get on the inversion table, you strap yourself in, you flip the table upside down, and gravity is creating that force for the separation. There's lots of things that are indicated for traction. It has many different effects on full body systems, so it requires a lot of monitoring and treatments. The published literature regarding traction is crazy. So it's just all over the place. Same thing with ultrasound. find studies saying it's the best thing ever, and then you find studies saying it doesn't do anything. So a lot of this probably because of the lack of specific studies and using old dated methods from the 70s. Claims range anywhere from profound, spectacular changes to absolutely no difference between traction and bed rest. And then the efficacy is it's controversial for both, but it's less controversial for cervical than it is for lumbar. Those of you that have had lab, I know this is kind of a refresher. But the controversies are on all of these different things. And that's what they mean by there's not been enough specific studies, where the study just studies the optical techniques, or just studies the frequency, or just the angle of pull. Typically, most of the studies you get for traction just kind of take all of this stuff into account and say it works or it doesn't. So there probably needs to be more studies done to isolate some of this stuff. And they have done some, which is how we get to 25 degrees of resting in the pool, 70 degrees of hip and knee flex. So there's been some studies, but there's just not enough. And evidence just isn't there to say. And that's why a lot of insurance companies will not reimburse for traction. So when we do traction, we just have to put it in our notes under therapeutic activity or something like that, because we have to note that we did it, but we can't charge for it because nobody will reimburse us. So here you got your therapeutic effects and your indications, good herniation, hypomobility. Right? What's the difference between hypo and hypermobility?
Mobility is stiffness. Hypermobility is when it's not.
So if you got a lot of laxity and you're hypermobile in your joints, probably not going to do traction. And then this slide is repeated again, just in case you forgot it.
That means it's important.
Longitudinal separation of cervical or lumbar spine, also called distraction. Distraction separation is the main goal with traction. So to achieve the separation of vertebrae, the force has to overcome counter forces, which in this case are typically just friction. It's the biggest counter force. So the patient laying on the table, traction force is applied to the head of the pelvis. So basically what we're talking about, the body stopped, it's in a stationary position, and we're trying to create movement. And then we have the friction of the table. And the example they use is starting to push a wheelchair. So if you have a heavier patient sitting stopped in a wheelchair, when you first go to start pushing them, it's pretty hard to get them to, not hard, but you gotta put in some work to get the wheelchair. And that's because of the friction between the wheels of the wheelchair on the earth. And then once you get it going, you get all kinds of other physics stuff, you get centrifugal force and all of that stuff that makes it easier to push. But that initial push is hard because of friction. Does that make sense, that analogy? The same thing when we tried to go do traction. You had a person laying on the table, and we're trying to pull. And there was a couple instances in lab where people didn't split that table, right? And so they started the traction machine starts to pull. We're only doing like 30 pounds. And they're like, all right, how's it feel? And the person on the table's like, I don't feel anything. And I walk around and say, hey, did you open the table? And then I hit the button, the table releases, you see them move a little bit more, and they go, oh, now I feel it. That's because 30 pounds wasn't enough to overcome that friction of the table to exert any force on the patient. So to get technical, the coefficient for static friction between a person and a treatment table is about 0.5. So it's about 50%. So to overcome the friction and to be therapeutic, we use a split table, and then for the cervical traction, we use that sliding track. Okay, so it slides easier, it moves, so there's less friction. But if we're talking about that 0.5, so say we're doing traction on a person and their head weighs 15 pounds. What's the amount of friction that we have to overcome to create that distraction force? 7.5. Correct. Good answer. So force can be applied applied either by the machine, gravity, or therapist hands. And then, oh yeah, just that 172 is that picture where it's kind of showing you put 100 pounds of force on the patient lying supine, and you have 80 pounds of actual force being applied, 40 up here. It kind of goes to that. But the biggest thing you need to remember is that it's that 0.5 is the coefficient. So if you have a certain weight, what's the amount of friction you have to overcome? That's the biggest thing that you need to know for that friction coefficient. Treatment goals. Increase cervical vertebrae separation, reduce nerve conduction disturbances, reduce alpha motor neuron excitability, and increase blood flow to the area. So for most of this stuff, anytime we're doing traction, you want to make sure you're still combining that with other movement-based therapies, strengthening, stretching, proprioceptive training, and make sure you're doing your patient education. The main goal with traction is to reduce those radicular symptoms. That's typically what you're going to see the most. The radicular symptoms being caused from like a disc protrusion, lateral stenosis, degenerative disc disease, or any subluxations or spondylolisthesis, things like that. Those are the big things. Things where we start getting impingement on the nerve roots, either through the sets or through the disc space, and they have that pain and burning and tingling down their extremities. We want to put them on traction, and the goal of traction is to reduce all of those symptoms and have that pain kind of centralized to the area. So when we're trying to reduce muscle guarding, we want to increase joint range of motion and get that distraction out. So while you're doing the traction, you have to assess their pain, numbness, tingling, decreased reflexes, muscle strength, all of that stuff, kind of before and after your treatment sessions to see if we're doing any good. If you have radicular pain, okay, test the reflexes, which I know you guys haven't gone over yet, but in the clinical setting, you want to know what the reflexes are, you want to see their strength, you want to test the strength, you want to test their sensations and touch, all of that. Do your traction, ask them how it is, and see that improvement over time. If it's not improving after several sessions, then we might not be doing anything, or it might not be doing enough. You can adjust your treatment. So the minimum amount of time for full muscular relaxation is 20 to 25 minutes. And that's typically the average amount of time that people are going to spend on traction. For cervical degenerative joint disease, I'll do about 25. For acute disc protrusions, no more than 8 minutes. So anything longer than 8 minutes with disc protrusions, it increases the fluid in that space, increases that intradiscal pressure, and it could exacerbate their symptoms and make everything feel worse. Which is why we want to check on them. Get them on there after 5 minutes, how you feeling, and then if there's more of those radiate pains, increased symptoms, we're not going to continue to do it. Just hope that it gets better over the next 10 minutes. And we're just going to stop. Frequency just depends on the type and severity of the problem and the duration that they get relief. So the first one, we usually go a little bit shorter time, a little bit less weight, so they're probably not going to get a ton of relief, but a lot of that is just to get people comfortable with the idea of being strapped down to a table with something pulling them apart. Right? There's just something inherently weird about that to people, and they're a little nervous. So if we get them on there and we crank it up to 40% of their body weight for a little while, we're just letting them sit there for 20 minutes and they're fighting the whole time. They're just tense and anxious about it. We're going to make those muscles get tighter. We're going to make all the symptoms worse. So we start low, build up, increase the pressure, increase the time over time, and then we kind of monitor the results. Hey, last time was great. I felt good for a day. But then, like, I'm right back to where I was. All right, well, let's try to bump up the weight a little bit. We'll try to spend a little bit more time, whatever. And that's what's going to determine how often you're using it. And at first, if it's going good, I'll do it every visit they come in for several visits. And then once they start feeling better, I'll start trying to incorporate more of the strengthening, stretching, the other stuff that we're in therapy for. then let them sit on the traction at the end. So that's what kind of we're talking about at the bottom here. The more acute it is, the more frequent you're going to do it, and then the more the neurological signs decrease, we can start backing down, do it every other visit to where we don't need to do it anymore because they're great, and we want to build up their strength and their posture and their stability so that it doesn't come back. Everybody go with that stuff so far? General traction. So cervical, again, we're reducing those particular signs. We want to see that centralization. Everybody know what I mean when I say that? Basically, a peripheralization is away down the limbs. Centralization is going to be more. Typically what you see is people come in, they're complaining of the burning and the numbness, tingling, prickly in extremity. As you start to do traction and your other treatments and stuff as well, that starts getting less. Maybe it doesn't come all the way down to the thumb anymore. Maybe it kind of just goes into the elbow. And then after a while, it's just kind of in the shoulder. That deltoid is a little burning, achy still. And then that kind of starts going away. And then they'll start complaining about, like, my neck is just super. Neck hurts, very stiff. So that's centralizing, right? The pain's coming away from the periphery and getting up towards the root of the issue. And that means we're making progress. So it's also important to make sure you're telling people that. Because a lot of times they don't notice the neck pain and stiffness and things like that. They just feel the burning and the irritation in the arm. And as things start to get better, they're like, well, yeah, my arm feels better, but now my neck hurts. So being able to explain that to them and help them understand that's a good thing is also important here. That's kind of what this is talking about. Ankle, back. So the best to reduce the muscle guarding and spasms is prolonged stretching, which is just static traction. And the way that helps is it decreases the pain through that gate control theory, where that's where we're breaking up that pain spasm, pain cycle by kind of blocking the pain signals to the brain because we're getting that stretch, we're getting relief, it feels good. And those signals will block the pain signals from coming in, which allow the muscles to relax for a little while. It increases joint range of motion, and then they just talked about how cervical traction is less controversial than the lumbar traction. Then we get into patient positions. 9 times out of 10, maybe even 9.9 times out of 10, it's going to be supine. Every now and then, I've seen maybe twice in the whole time I've been at PTA, someone do it prone. Never seen sitting. A lot of the old traction stuff that they used to give patients at home, they would do sitting, but now they just give the Saunders cervical traction. It's kind of like we use here, just a portable one with a bicycle pump. Like you pump up the air, and then they do that. So you don't see a lot of sitting anymore, but you may. But supine is the preferable one because it's more relaxing for the patient because people don't like to be face down on their stomach forever. It requires less force to separate the vertebrae, and it's also preferable over the sitting. Some people just can't lay on their back, so you might have to use the sitting. I've never used it. Sitting takes up less space in the clinic, and you can use it for people who can't lay down. Prone, you rarely ever see. So the big thing with most disc protrusions and things like that are happening. You get impingement through the facets, you get protrusions posteriorly, and since they're most of the time posteriorly, we get that cervical traction, and it kind of puts you in a little bit of flexion. And when you go to flexion, we're closing off the anterior disc space, and then open it up a little bit to kind of stretch out those posterior muscles. If it's a really big bulge, you need to push it back. Sometimes they'll go prone. So it pulls more this way, but rarely. So,
If they were in a seated position, would you have to use more weight to make up for the weight of their head?
essentially, you still stick to kind of the same percentages of body weights and things like that to start. And depending on their response and things like that, you can start acting up a little bit. But just that same 7 to 10% kind of stuff we talked about now that we'll get to. not that big of a deal because that force is pulling that much pound on, even with gravity, because gravity's working on that bag as well as the resistance. So it kind of almost equals out, not really.
I was thinking gravity would have a little more effect in the seated position as opposed to
Absolutely, I mean, it does, you're right. But still, you would just go by your same numbers and then bump it up the next visit. You don't want to just be guessing like, well, how do you 10 more pounds to counter gravity here, right? And then that's too much. So I'd still start with your same percentages. And if you're like, hey, I didn't really feel much difference, all right, cool, let's add a little bit more this time. Some of this is kind of trial and error. Okay? We have some guides on where we should start most of the time, and that's just typically where we're going to start because that's the safest, that's the easiest. It makes them feel more comfortable. If they get a good response, they're more willing to try more weight, more time. So kind of just building that rapport with the machine, with you the first couple times, and then it's gonna get crazy. Not too crazy. So you got an occipital device, which is a Saunders unit. That looks just like the one we use downstairs. The ones they send you at home just have a little base that sits on, and then a bicycle pump that attaches, that'll pump up. Where here we use the machine to pull. At home they can just use a pump. So lay their head on the headrest by the forehead strap. So they use a paper towel for hygiene. I just wipe it down. But if you want to follow the slides, put the paper towel in there. Sometimes I will if it's the one we were using in the lab yesterday is a softer strap. The one that somebody wrote was a harder, more finer strap, and it just doesn't feel good. So I will put paper towels or something under that one. But then you want to tighten the pads till they're snug but not uncomfortable. I was doing that yesterday. People's carotid off. But this helps eliminate the pressure on the TMJ and is more comfortable compared to, this is kind of how we were used for the overhead, or the seated one. We kind of go under the mandible and under the occiput, and then that reaches up and straps onto the hanging thing that we're going to pull. So it's called a head halter, and that's used to be primarily used for home units until they started sending these home. Put it around the mandible and occiput. The pull should be primarily felt on the occiput and not the chin. So you usually face the patient towards the door when you're using those, and adjust the angle of pull to eliminate pain on the chin. So scoot them in or out based on whether they're feeling more from the chin or more from the occiput. So far, so good. So we talk about angle of pull. The most generally accepted through some of the studies that they have done is that 25 degrees of flexion is the most optimal to increase the intervertebral space. But that it varies depending on target tissues. And like I was showing someone in the lab last Tuesday, some of the assessments we can use in the clinic to find out which vertebrae or what area where there's more limitations and things like that. For that atlas axis rotation and movement there, you have someone kind of in a neutral spine. You can check the movement there, and then as you increase that angle of flexion, we're kind of working down. So you put them in a little bit more flexion, we can get into C3. And we kind of check C3's movement, and then we take up more of that space and put more flexion, and we can kind of walk down the vertebrae. And this is way advanced. But that's kind of what that means by depending on target tissue, target area, or if it's just muscle. But depending on that, we can change the angle. But generally, 25 degrees is where we're going to be. Intermittent traction during the 20 or 25 minutes is the most comfortable. Generally, the static pull gets a little annoying, so you can cycle the time based on the patient's tolerance and their response to the treatment. So even though static is going to be best for muscle relaxation and guarding, if they don't like it, we can always just drop back to an intermittent traction. Because more tolerable for the people. So, initial treatment, 5 to 10 minutes to assess their response. And then you can do static, you can go anywhere from 3 to 30 minutes, but you're gonna use less force. That's the other benefit with the intermittent traction, is people can generally tolerate a stronger pull because they're having that break in between. If you put a stronger pull and you keep it on for 20, 25, 30 minutes, people start to just naturally start to guard. Right? They don't even do it on purpose. They just constantly have that tension, that stretch on the muscles, and over time the muscle starts fighting back. Like, all right, that's enough. And then if you do it too long, they're gonna be fighting that force, and you're gonna irritate and tighten up the muscles even more. So, static traction, we're gonna probably do a lower load for a longer duration. So, the shorter amount of time that you have them on there, the shorter amount of pull and poundage is the most common. So, just don't crank it up for a static. So, human head average weighs about 14 pounds, usually 8% of the body weight. So, we need at least 10 pounds to cover friction or gravity, and then 14 pounds to actually lift the head and have it float off. 25 pounds where we need to be to separate the vertebrae, to get that spine to stretch out a little bit. So upper cervical requires less force than the lower spine, which is what we were talking about a second ago, that angle of pull. So if we're trying to get more up in the C1, 2, or 3, we can be a little more flat, and then it increases as we go down the vertebrae. Most people that have vertebral issues or any kind of disc issues are going to be C4 to C6 typically. That's where that forward head starts coming in, and that's where that C4 through 6 is typically the issue. So that's why, again, that 25-degree angle is typically the most used. 12 to 15 pounds is adequate to treat muscle spasm and stretch soft tissue. Generally, the first treatment, 8 to 10 pounds. 40 to 55, probably produce some muscle guarding. So for a soft tissue stretch, muscle spasm, disc protrusions, we're looking at between 7 and 10%, which is typically about 11 to 15 pounds. Again, 7 to 10% of their body weight for a soft tissue stretch to treat muscle spasms, to treat disc protrusions, 7 to 10%. And if we're looking for just joint distraction, for any facet issues, stenosis, any kind of spinal and structural things, we're looking 13 to 20%, which is generally going to be 20 to 30 pounds. So, spinal issues, joint separation, we want 13 to 20%, but typically, as a whole, we're not going to do more than 30 pounds for certain, because as we get higher, we're going to increase the amount of muscle guarding, and we're not going to get anything done to make it worse. Any questions on those percentages? Everybody good on that?
Can you repeat them one more time?
7 to 10%. We're treating soft tissue, muscle spasm, disc protrusion. And then 13 to 20% is for that joint distraction. So we need to get that vertebrae separated. So that's typically where that 13 to 20% usually is about 20 to 30 pounds, so that we actually get that separation to treat those spinal issues, facets, stenosis, things like that. Any questions? All right, then we get into the hold relax times. So for muscle relaxation and joint capsule stretching, that's that, again, that low load, longer duration. So that's a static traction. So we'll go lesser weight, maybe more around that 25, 30%. This is still cervical, it's probably that 13 to 20%. But for a static hold to treat muscles. For disc problems, and that's true disc herniations, we're talking mostly more acute disc problems. We want that 3 to 1 ratio where we're 60 seconds on our hold and 20 seconds for our rest. And it says 3 to 1 or 1 to 3. 3 to 1's the most common because the hold, the pull is generally where it feels good. We're decreasing the pressure on the disc, we're just decreasing the pressure on the nerve. So that's the feel good part. And then the off is when we let that tension go. And that's where they live their life. So typically it's at 3 to 1, but sometimes having that hold for longer irritates things, especially the more acute it is. So you might switch it and start with a less hold. But generally it's going to be that 3 to 1. And again, for the spinal joint problems, we want intermittent again, but at a 1 to 1 ratio. So whatever that 1 to 1 is going to be, and the more severe, the more acute the condition is, the longer you're going to make these hold and relax times. So you might do 30, 45, 60-second hold with a 60-second release. And as their symptoms start to improve, we can lessen that amount of time. Because right now, when they have spinal joint problems, the muscles surrounding those joints and those vertebrae respond to the pain with spasm, right? So we gotta get those muscles to calm down a little bit. And if we just start cranking on it, it might make them more angry. So we'll relax them for longer periods. And then as the pain starts to come down and their symptoms are a little less, we can start to shorten that hold and relax time to closer to 3 or 5 seconds. So then we're getting more of a oscillatory motion because the whole point of therapy is we're trying to get people to move again, right? That's our job. They come in with spinal joint issues and everything's stiff and the muscles are tight and the spine's just not moving. We're trying to get it moving again. But if we do a lot of movement early on, it just irritates and aggravates the muscles and everything. And we don't get anything. So we do longer hold relax to help everything stretch. And then as the pain goes down, we start to decrease from 60 to 45, 30 to 10, all the way down to 3 or 5 seconds. So now we're getting that movement, how we would be walking around. And so we're trying to just create that motion. Any questions with that? Our on-off times. So if I just want to stretch soft tissue and get the joint capsule moving, what am I going to use?
Seven.
Huh? Static. Not all at once.
Static.
Alright, so what if it's a disc issue?
3 to 1.
3 to 1. So what kind of traction would we call that? Intermittent. Awesome. And then for structural facet issues or stenosis, what am I using? Which is, what type of traction is it? Intermittent. That's the biggest thing I want to remember. Those are important. Then we also have progressive and regressive. So you can use that with either intermittent or static traction. And basically it's just a stair step, right? So the time that they're on, it's set to gradually bump up and go down. So if you wanted to do a progressive regressive with intermittent, you would bump it up and then slowly bump it down, and bump it back up, and then bump it back down, and that would be an intermittent progressive regressive. You can do it for static. We want to try to get to a goal of 50 pounds. We can kind of start at 30, whatever, and start bumping it up over time until we get to that 30 pounds. And it's more of a static goal. It allows for gradual increasing or decreasing, which is that stair step that we talked about. But some patients say it's too jerky, they don't like all that extra movement. Sometimes it can improve the tolerance to longer, more forceful holds. I've rarely ever used anything like that. Typically it's either static or intermittent that I've seen used. But that is an option. Then other traction devices that we have auto traction with the patient applies the force. That's what this guy's doing down here. They just kind of head stays still. They got this rope hooked up to their shoulders and they push with their feet. Kind of creates separation. Over the door units, we talked about the disadvantages there. We have to have a cervical halter, which increases the risk of TMJ dysfunction, aggravating that TMJ. And then you have pneumatic home cervical units. There's an older one right here. Nowadays, you see the ones very similar that we use in the lab with the bicycle pumps to create that pool. Then we have the manual traction. Therapist applies the traction force, or the patient can apply the traction force, like that other person over there. You can do this supine or seated. Seated is just funky because then you have to get like under the mandible, kind of like the overhead, like the over the door units. So then you're trying to get under the occiput and the mandible and basically lift them from their head. It's not comfortable for the patient. It's not really comfortable for you. So supine is the best, but if they can't lay supine, that may be the best you got. And then like I've been saying in the lab, anytime I'm gonna do traction on somebody for the first time, before I do the mechanical traction, I'm gonna do some manual traction first, just to make sure it's not gonna aggravate the symptoms. Because as everybody that's been in the labs already knows, it takes a minute to get those set up sometimes, turn the machine on, and get your settings right. And then you start, and within the first 3-5 minutes, they're like, oh, this is not fun. My pain has gotten worse, and then you have to break it all down for them. So I'll always start with some manual traction to make sure it's not gonna aggravate them, they're comfortable with it. And even then, especially for cervical, when you get under there and you're gonna pull and get some distraction on that cervical spine, I'll always remind them that, hey, I'm not a chiropractor, I'm not gonna snap your neck or anything, because as soon as you put your hands under people's heads, they just tense up. Half the time it's because they're waiting for you to try to snap their neck. Sometimes it's just because they're trying to help you hold their head up. So you have to tell them to just let me have it. I'm not gonna twist it or do anything. We're just gonna try and see if this traction is gonna feel okay. Try to get them at ease. But that's what I'll typically start with, cervical and lumbar. And then you have positional traction, where this is a cervical kind of pillow. They also have things called like a dinner roll, DE and N. But it looks very similar to that, and it's just prolonged placement positionally that gravity starts to apply tension where the head is hanging off, and it helps to open up the facets, intervertebral foramen, and allows gravity to help distract the joints. Alright, I'm gonna need another break for a minute to get some water, and then we'll get into some lumbar. Extended, legs more straight, get the anterior surfaces. So prone allows us to get some modalities and other stuff done while they're on traction. It's another advantage of the prone. You can do some soft tissue work, maybe some cupping of the muscles while they're having that traction. Apply some heat, whatever it is you want to do in that prone position. And then the angle of pull, in order to maximize separation, the pull of traction should occur perpendicular to the surface acted upon. So for the upper discs, more horizontal. We're trying to get down to L5S1, a 30-degree angle of pelvic tilt or in prone is easier. And we can also adjust that by moving the table up or down to change that line of pull. For disc protrusions and stuff like that, supine with the legs straight, kind of increasing that lordosis in the back, is going to be better to get like disc protrusions. And then supine with the hips and knees flexed between 70 and 90, we get more of a kyphotic, like kyphosis, and that's going to be better for like lateral stenosis, spondylolisthesis, spondylosis. And then there's a picture on page 180 that shows the difference between prone and supine, kind of around the lumbosacral joint, where it shows you opening up different spaces based on what you're trying to attack. So that gives you an idea on whether or not you want to be prone or supine. L5 and S1 joint is the least affected typically. with the traction. It's just hard to get that one to move. So when we're doing traction, we have the thoracic harness, and that's what we're using to apply that counter pressure and kind of negate some of that friction. So sometimes you have to wear it next to the skin to eliminate slippage based on the slab. I've never seen that in practice. You can usually tighten these things down pretty good when they're not going to slip. But we want to be between ribs 8 to 10 and below the breasts. And sometimes the bottom part of that is going to overlap the pelvic harness. That's normal. It's okay. And then we attach that thoracic harness to the head of the table with either clips or that little hook that we've been having in labs this week. And the other harness is our pelvic harness. So superior margin should be just above the iliac crest, kind of overlapping that thoracic harness sometimes. And then the straps are attached to the traction unit. So it should be snug at the iliac crest, and they also need to go directly on the skin, which again, they tighten down pretty good. And then from my personal experience, what I've been telling everybody in the lab is I like the 2 fingers. So where my top finger is lined up with the top of the pelvic harness, and then their iliac crest sits right under my second finger. For me, that's the best. I feel comfortable there because when we tighten it down, we're holding on to the pelvis. It's not going to slip off because we're up above it enough to grab it a little bit. And you don't want it to be too loose that it slides down, and you don't want to put it on too low because then we're just pressing in the hips, and we're putting tension on the hips, and then we essentially start just pulling from the finger and not from the pelvis. And then the one strap that we have down there, it just wraps across everything. You want to make sure that the bands that they're laying on are going to be pulling straight down too. There was a couple times yesterday where things got moved around, and when we went to hook up the harness, it had shifted. It was all on the left side of somebody, and it was really just going to pull more from that left side. So make sure that's in the middle, and then with the other black one, the pads on there kind of look like pelvis. You want to kind of position those so that they are where the pelvis is. We don't want both of them around on the back side, because then we're going to be kind of lifting up more than getting them pulled down, and we don't want them too far on the front because then you're not really grabbing the pelvis. So put them where they grab more of that bone. So when we talk about static versus intermittent, the comfort of the patient cannot be overlooked when we're talking about this. So even if static traction is probably more indicated, we're trying to open up joint space, extract the joint, release some soft tissue, we know static's probably going to do that best at a lower level. But they just don't like static traction. It doesn't feel comfortable. Do intermittent? Okay. They're still going to get the benefits. But if they're not liking it, they get irritated, they're going to get tight, anxious, and then we're not helping them anymore. So that's one of the biggest adverse responses that we got to keep in mind. Comfortable doing something. So again, static traction, just like in the cervical spine, is going to be a longer duration at a lower load. So constant force, less force is required and tolerated. So some research suggests that using static for muscle relaxation and consent joint stretching, but patient comfort is the primary guide. Again, they just don't like the static. So any kind of disc pathology, we want to avoid longer pull times because we can increase that intradisc pressure. How many minutes are we thinking for any disc issues? 8. 8 for sure in the lumbar. You can probably get 8 to 10, or 8 to 10 in the lumbar. 8 for sure cervical, but just remember 8. It will be said. So that's static. Intermittent traction alternately applies and releases the traction from brief intervals. You can adjust the on-off times for herniated discs. Again, that 3-to-1 ratio. And the advantage is the patient tolerates more force, which gives us more effective distraction. No idea what this is. I haven't looked yet. Y'all want to
Yeah.
Oh. Yes.
They thought surgery was the only way to fix this, until this happened. This $60 military device, equipped
You don't
with
gotta think about
BioAlign
that.
technology, realigns your body to optimize spinal health, setting a new
Patient's gonna
standard
ask
for
you
the
about it, I
industry.
guarantee you. I get asked
And
this
its
at least once a week.
unprecedented success is
I
leading
saw this thing
chiropractors
online.
across the nation
What are you
to
gonna tell your
dust.
patients?
It has sold over 2 million units in the last 30 days, all without the help of Amazon or Walmart. It's called TrueFit, and it's been
That's
featured
gonna
on
make your
Fox,
muscles weaker.
ABC, and
So
NBC
now that
a few
device is
times.
holding you upright. We want
Ever
to train
since
your
its
muscles
launch,
to do
the
it.
effectiveness of TrueFit has
Start wearing
threatened
that.
to disrupt traditional medical
It's gonna get
treatments
worse.
and
The
rehabilitation
condition gets worse
practices,
every time.
resulting in pushback from insurance companies.
For lumbar, I'll tell people if they're out working, lifting, and listen.
Hi, I'm Dr. Clint Witzman at Champion Fitness Physical Therapy in our Pontiac clinic. Today we're going to be talking to you about our traction unit that we have in our clinic here in Pontiac. A great alternative for treatment of low back pain and cervical pain because we can use it for both. We'll explain to you how it works and what it actually does for you and how it can affect your spine and help decrease your pain. I'll go ahead and I'll show you the unit here first so you can see what it looks like. Pretty nice soft table. The table moves up and down, so if you're shorter, we can get down to there. And if you're a lot taller, we can bring it up to make it more comfortable for you as we get you hooked up. Really, traction and decompression tend to be a very interesting, nice little stretch. If there's any muscle spasms, the hardest part is getting the belts on. Once we have the belts on, it's all easy. So I just have to palpate Kristen here, find where I want the belts. Go ahead and put your arms up overhead for me. Good. A lot of people don't like the tightness of the belt, but the nice thing is with this unit, we don't have to have it too tight. It actually can be fairly loose. So that's the nice thing. Kristen, how's that tightness-wise? It's just snug, right? Yeah. So it doesn't have to be too tight. So if you're a little claustrophobic, this shouldn't bother you too much. You can see right now I'm putting on the lower belt, which the traction unit will actually pull on to help separate those vertebra and help everything to get a nice little stretch and hopefully help the patient feel better within a couple treatments. So there we go, Kristen. Good. Hands back up overhead for me. The upper belt, same thing. Doesn't have to be too tight, so we just make sure it's nice and snug. Kristen, go ahead and breathe out for me. Good. And then we just snug this down. Just like that. You can go ahead and relax. We'll give Kristen some pillows here. Like that. Go ahead and bend up both knees for me. The cool thing about this unit is that we can do traction on your back like this. We can do it laying on her belly, or we can do it laying on her side. So we can find a comfortable position to make everything, more. So we're just going to pull the rope out here. Connect it to the belt. Kristen, are you pretty comfortable right now? Yeah. Good. That's the point of traction, is to be nice and comfortable. I have a button here that I'll give to Kristen. If it starts to hurt or if something's not going right, she just doesn't feel good or she feels some claustrophobic, she can hit that button, everything will stop, the buzzer will go off, and we'll come back and find out what's
Mr. Carver, I just want to point out that guy said filler words like over 25 times,
Yeah.
at least.
I'm not gonna judge him because I have to sit up here and do this all the time. It's harder to not do that, but I think I do all right. But it is hard, so I'm not gonna say I never do it. 'Cause, okay. In order to get separation of the spinal segments, 50% is necessary to get that spinal nerve root or facet joint decompression. So that's kind of where we want to work up to that 50%. That's where you're going to do your best separation, the best distraction forces, but we're obviously not going to start at 50%. Usually start around at 25% because that's going to help us decrease the muscle spasm, stretch out the soft tissue. So for soft tissue, just like in cervical, we had those percentages. For soft tissue, muscle spasm, we want 25% for lumbar to get any spinal separation. We want to be closer to that 50%. But we don't ever want to go over 50%. And then sources indicate that a max of 30 pounds is best used for that first traction session. Again, people aren't super comfortable to begin with when you start hooking them up and strapping them down to a table and pulling them apart. There's a little bit of nerves there, so they're gonna have some of that guarding. And when the machine starts to pull, they feel that traction force, and they tend to start fighting it. A lot of that's subconscious, they don't do it on purpose, they're just anxious. But over time, after the first session, hey, that felt good, I had some relief, they're a little more willing to go up on some poundage and can have less guarding. So first session, we'll probably stick to that 30 pounds of pressure. And then our hold and relax times are very similar again to what they were for cervical. Treatment of disc problems, we want that 3-to-1 ratio. The example here, 60-second hold, 20 seconds relax. For any of the spinal joint issues, facets, stenosis, things like that, 15 seconds, that's our intermittent 1-to-1 ratio. And then some of the examples that I used in labs said degenerative disc disease. And I know that has the word disc in it, but typically we're gonna treat that more like a spinal joint problem, because all that's happened there is the disc space has lessened over time with age and activity, and so the bones are a little closer together, the space is reduced, and we want to just open that space up. So even though it has the word disc in it, it's not a disc 3-to-1 ratio type of thing like a herniated or prolapsed, whatever disc issues, nerve root injury. So just wanted to clear that. Severe symptoms, we want the longer hold and relax times, and we can work our way down to that 3 to 5 seconds again to work on that oscillatory movement. Just like with cervical, we have progressive and regressive. This slide's pretty much the same as it was for cervical. Sometimes it can help patients tolerate a little more load because we work our way up gradually, but some people don't like the constant movement of a progressive or a regressive traction. Again, treatment time depends on your desired effect and tends to be shorter for disc herniations. Here it says 10 minutes or less. Again, lumbar you can probably do 10. If you want to just remember 8, 8's good. Because if you're thinking 8 and 8's not an option, but 10 is, you'll probably pick 10, right? So longer for spondylosis, we go about 25 minutes. So traction longer than 8 with disc protrusions can cause the disc to imbibe excess fluid and increase the intradiscal pressure, which is why we're just sticking to 8 when we talk about any kind of disc issues.
Spondylosis is your 1-to-1?
Yes. Yes. So a successful treatment depends on patient experience, and then here's where we're talking about that quick release that we talked about in lab, especially with cervical, but it happens with lumbar too. When we have dizziness, headache, increased pain or symptoms, when there's a quick release, and we have them on traction for 20 minutes, and it's like, all right, now it's time to get off, and we take the traction off, unbuckle them, have them sit up, kick them out the door. Usually doesn't feel good. Things get crazy sometimes, right? So some of this is also caused by intradiscal pressure, which also causes some decreased blood pressure, which is why some of the cardiovascular issues are contraindicated. Blood pressure can drop all around there, laying horizontal, and we're getting all that pressure. So to prevent issues, we're going to release it slowly, which those machines typically, when they stop or if they hit the button, it does come down slow. It's not like a quick jump. And then once it's released, we're going to let them stay on the table for a few minutes. Typically, I'll go ahead and unhook the cable. I'll chat with them a little bit. How'd you feel? How'd you like it? Get some subjective information while we're waiting. And then I'll loosen up the straps pretty quickly so that they don't feel like they're in a corset still. And while we're talking, loosen the straps up, take them off, unfold them, tell them, hey, just stay here on the table for a second. I'll help you get your legs out from the bolster or the traction stool. Put them in hook line, don't put them immediately straight, right? Because as soon as we straighten out the legs, we get that lordosis, which puts pressure right back on the back. So when you take their legs off, kind of gotta, hey, put your feet down on the table so that they stay in more of a neutral spine. And then once they get up on the side of the bed, or while they're laying, we can do some ankle pumps, circles, some glute squeezes, especially with the older patients that you feel like you might be worried about some blood pressure issue. Get the blood flowing, get some things pumping, so that we don't have a lot of this other stuff going on. And then we want to monitor the symptoms before, during, and after traction, which is the same with any modality. We talked about it earlier. If they have the radicular pain, check that, check their sensation, check all that stuff. Ask them how it is on the traction, because if it's getting worse, stop. Typically with traction, their symptoms are going to go away while they're on it. But once you take them off traction, unless you get them sitting up, the symptoms can kind of slowly start to return. That's normal, but what it tells us is that we can make an effect on it, and we can change it. So that's good news. And the more we do traction, obviously with our other exercises, things like that, the more we can get rid of this stuff forever and ever. You ever look at these two? Let's just see. If they're garbage, we'll pick them. Nope, can't watch that one. See how easy that was? Let's see this one.
Place the Swedish foam pillow at the top of the unit, hand pump gauge, and stop
There you go.
pumping when the
That
recommended
one,
amount of
people
traction
were telling
force
me they
has
had
been
in their
attained.
place.
Yep.
The hand pump
Yep.
will hold the pressure automatically. Comfort Track features a high-quality gauge designed to be extremely accurate. If the traction force reading drops, it was probably caused by repositioning.
So this is why a lot
To
of the home
rectify,
stuff
slowly
isn't
pump the air
over the
cylinder
door
back
stuff
to the
and
desired
gravity, 'cause
reading and
nowadays most
relax.
people get these.
If you pump the air cylinder beyond your recommended traction force, press the release button immediately until the correct traction force.
But it's the same stuff that we're doing, and the manual's just not gonna happen. So, awesome. But those other ones, that Comfort Track is actually really good to have at home with the cervical. Look just like the bicycle pump and everything, but then the cervical looks exactly like what's in the lab, but instead of being hooked to something that's on a base, what I have, the base is adjustable from 10 degrees up to 25 or 35 degrees angle, so depending on what you're trying to get. The home devices have gotten a lot better. Positional traction we talked about way back at the beginning. I still consider this gravity, because gravity is still having an effect on what you're doing. You're pulling your body weight down. So we're trying to get the opening of those intervertebral foramen, and we can do this by flexing the hips up, knees, and then rotating the shoulders in opposite directions. So those foramen in the facet joints over here get narrowed down, and they're like this. When he lays down over that towel roll, it's going to open them up, and then we can work on rotation, kind of stretching out those muscles, opening up that joint space on a unilateral side. And then double knees to chest. I'm sure anybody that's been to tech grenade or anything in any clinic has seen it done. Single knees and double knees to chest. It's just going to help us open up the intervertebral foramen bilaterally and get some separation of the spinous processes to open that joint space. Any questions so far? This stuff's easy, right? Everybody's gonna make 100 on this next test, right? Put that positivity out there. Yep, we are. Will that stuff? Alright, do the last few slides. So this picture is just kind of recycled through the last few slides. Where the red box is kind of what we're talking about. So this is a normal disc in a non-compressed position. And that's what they look like. The internal pressure, which is indicated by our arrows, shows that it exerts pressure equally in all directions. These little annular fibers are our discs. And then they contain all of our nuclear materials of that disc called gel. So this is normal. That's where we're happy with life. As we get over here, we have an injured disc, where sitting and standing compresses the disc, causing the nucleus to become a little bit flatter. So mechanical spinal traction can exacerbate medial disc protrusions. So that's again why we want the interval and we want to check in with their symptoms. Yeah, we can help them, but also we can increase that pressure when it starts to feel separation, doesn't feel good, they don't like it. And then this is another injured disc where movement and weight bearing causes a horizontal shift. So we get that right, it's kind of side bending and then pushing all the stuff out to the left side. So if this was forward bending, the bulge would be posterior and the annular fibers here get stretched and taut and the ones here get lax. Everything pushes out. Then we have herniation. So this is where we finally say, oh, you've got a herniated disc because some of the jelly has pushed through those annular fibers that are kind of holding it in space. So this can start putting pressures on sensitive structures in the area. What sensitive structures, you ask? I'm glad you asked. The spinal cord runs right back behind all these vertebrae. So as soon as something starts pushing out into the space where it lives, it can start touching on it. And nerves are very picky and they're angry and they don't like anybody messing with them. And when you do, it tells you about it. And that's where we get those ridiculous burning, tingling, and pins and needles from that being pressed into that spinal cord. And then when we put any of this in traction, we increase that intervertebral space, decreasing the pressure on the disc. We need a maximum, or to get maximum separation, we need at least 7 seconds of that separation. So if we're doing our intermittent ratio of 10 seconds on, 10 seconds off, we're solid. As we get down to that 5 or 3 seconds, we're not getting that release. But again, when we get down to that 3 and 5 seconds, we're just trying to get it used to moving. So this is kind of normal. These are all of our issues that we're treating. This is what it looks like while it's getting treated. It's basically what this slide is trying to show you. Cool? Okay. So now, just like we did for ultrasound, I'm going to do it again for these couple slides. So we can start with traction. We do it for the aquatics. We're going to go to our lab groups. We're going to come up with 3 good questions. And again, I'm doing this because I think it helps you understand how to look for information and better study for a test. So let's just do 2 questions since we're doing 2 different PowerPoints. Each lab group give me 2 questions on traction. Just split them in thirds. How many is there? So roughly 15 apiece again. So first, second, third, 15 based on where you guys set up. And we do the same thing for aquatic.